Welcome, everyone. Thank you for joining us today. As Dr. Godrej said, we do have a fantastic panel of experts who are not just experts in their respective fields in mental health, but they really know a lot about OCD. And I think that this could be a really definitive conversation on the topic, at least for us in India and perhaps for other parts of the world also. I'll just say a little bit about myself to set the context. I have a lived experience of a serious mental health condition for the last 2 decades. I've been living with something called bipolar disorder. And this year I wrote a book called Chemical Khichdi: How I Hacked My Mental Health, which came out earlier this year. And what it's allowed me to do is to have a conversation with ordinary people as well as some mental health professionals about mental health in India. And what I've really realized is, how, as we all know, but I think when you have a firsthand experience of it, is just how much stigma there is, how much lack of understanding there is. And certainly when it comes to illnesses which affect a minority of the population, which is something like bipolar or something like OCD, there are just so many myths around it. So I don't want to spend any more time on apart from the conversation and dive right straight into it. So Dr. Reddy, you've had an OCD clinic for 25 years at NIMHANS and, just tremendous experience. But can we keep it to, for a basic layperson to understand, what exactly is OCD? What are its symptoms? If you could share that.
Yeah. I think everyone associates OCD with someone who washes hands excessively or who checks unnecessarily. But there are a constellation of symptoms. Basically, OCD is characterized by having certain thoughts which you don't want. They're unwanted. Sometimes they're very absurd, irrational, but then they persist in your mind beyond the point of relevance to the extent of causing anxiety. And then to get rid of that anxiety, you start doing certain behaviors repeatedly, although they may not always be realistically connected to the thoughts. For example, most common symptom is fear of contamination with things which are dirty or germs. So you may fear that you can get one, or you may spread the disease to others, or simply many people don't really have this fear of contamination, but they're just disgusted with things which most of us don't. And then they keep washing and cleaning to the point that they feel, they spend hours together. There's one very, very common symptom, almost synonymous with OCD. Then the other one is actually you keep checking things again and again. For example, checking your door lock or your gas knobs. There are people who check for hours before they leave home, or sometimes you check to make sure that you haven't harmed somebody. Say, for example, you are driving, you keep constantly checking to make sure that you're not run over somebody else. And it can actually be problematic because you may end up actually doing so because if you're doing that in the busy traffic. I've heard people like that. And then there are people who also get certain repugnant sexual thoughts or violent, horrifying images, thoughts of harming self, thoughts of harming others, although they don't have an intention to do so. And then the other common thing is thoughts about scrupulosity, thoughts of religion, God. Most common thing is, people get the abuses whenever they start praying God. So these are very, very common symptoms of OCD. And there are people who spend a lot of time arranging and things in a symmetrical way just to make sure that they're either symmetrical or sometimes they arrange things because of fear that if they don't do, something terrible might happen. So these are some of the very, very common symptoms of OCD. And at one end, these things are there in all of us. Okay, OCD is about certain behaviors which are there in general population, persisting beyond a point of relevance. We all wash, clean, check. We all get random, repugnant thought, but we are able to dismiss them. So when they become, they start consuming time, they cause distress, and you spend hours in performing rituals, that's when it becomes a problem.
So what's very interesting is what you said is really that a person has got these unwanted thoughts, and the behaviors that we associate is casually with OCD are really a response to those thoughts. So we'll go deeper into that. So Dr. Motivala, you also have been researching this a lot, and you're based in LA, I believe?
That's right.
So now, how does a layperson really know that it's time to visit a doctor for something like this? Like, how does one really arrive at a diagnosis in your experience with a condition such as this?
That's a great question. And I think one of the difficulties with OCD is that it can take a lot of time to get an accurate diagnosis. I think there's two big challenges we face. The first challenge is helping OCD be a better understood condition in the general population, so that so that the layperson has a better understanding of what OCD is and what it isn't. Unfortunately, it seems to be a term that some people use to describe being really organized or really, really particular. And unfortunately, that's not actually related to having the condition at all. I've even heard people say things like, what a relief that you have OCD. You can get this job done in a really diligent, kind of way. And that's really a misuse of the term completely, and it's very misleading. So I think that's the first challenge, is to do outreach and improve people's understandings. And the good news is, when I started when I started specializing in this area many years ago, the degree of miseducation or misinformation about it was so much worse. I think that there's so many more accessible resources for people to learn about OCD. I think the second challenge is with medical, psychiatric and psychological practitioners, helping them become more experienced about assessing, diagnosing, and treating OCD. I think there's still a huge lag in practitioners' knowledge about how to treat OCD. I also think there are a lot of practitioners that think they know how to treat OCD, but just don't have the right training. A lot of generalists who think they can do it, but you really do, at least on the behavioral side of things, you need specialized training to help people with OCD.
No, we'll come back to the treatment, but what I was really, as you said, that, this is a condition where even a 12-year-old might say, I think I have OCD, right? So how does one, commonly in mental health, we all say that, we're all somewhere on the spectrum, really. So in this case, it really seems that everyone thinks they're on the spectrum. So how does one really distinguish between that and say that this is a time to investigate this? Because it also does occur with other mental health conditions very frequently too.
Yep.
So if you had to tell just the audience to say, this is actually a time when you think, you might have OCD, how do you, how would you advise them?
I think for any mental health issue, there's two big factors that you would think about reaching out to a practitioner. The first factor is impairment. How is this impairing your life? If you're a child, how is this affecting your academics in school? How is this affecting your peer relationships? In OCD in particular, you see profound effects on peer relationships and friendships and relationships. So the first thing to look at would be impairment. The second thing to look at would be distress. How distressed are you from these things that you're dealing with? If you're engaging in a behavioral routine so excessively that it's causing distress to you, that's a time to seek out help. So I think keeping these two things in mind, impairments in your role functioning in your daily life, and then also the distress level that you're experiencing. So.
Yeah, that's really good. Impairments and distress. It's a good, wayfinding system for people dealing with something like this. Dr. Marker, what would you say are the demographics looking like in a country like ours? Especially you deal with a lot of young people, adolescents and children in your practice. So how does one, is there a particular demographic that's affected more by something like this? How does it manifest itself in children? Dr. Motivala was talking about that a lot.
Sure. So I think from the demographics perspective, I think universally OCD is supposed to be more prevalent in, women and less in males. But there is no real, research keeps changing and the incidences keep changing. I think what's important to understand is the age of onset. So I think when you look at childhood OCD, it is as young as 8 years of age. So between 8 and 12 is the first kind of age group for the onset of OCD symptoms in children. And then, of course, your teenage life to young adulthood, where it usually starts manifesting in itself. What's interesting to know that the age of onset of OCD is younger in boys than in girls. And we've actually seen that in our clinical practice because now, I don't know whether it's the COVID or COVID-related aspects of mental health and OCD, but we're seeing even kids as young as 7 and 8 years of age manifesting with severe symptoms of this disorder. In terms of prevalence, the latest statistics also show that 1 in 200 children have a diagnosed OCD. That's as, if not more prevalent than the prevalence of diabetes in children. So you can imagine how high that is. And with children and adolescents, it becomes a bit harder from the diagnostic perspective. I think the two reasons why is because, I think world over, we've just discussed, right, why there's always from the onset of symptoms to the time that a child or even a young adult receives help in any way. The WHO states that it's almost 8 to 10 years sometimes. That's how delayed the onset of treatment can get, especially when it comes to mental health concerns. And with children and OCD primarily, I think it's a lot of embarrassment. When I work with kids, the first thing that comes to light is how much of it that they suppress and repress. So they don't even actually know what's going on because it starts so much at a cognitive level, and most symptoms start with intrusive, obsessive thoughts that they actually either fear it or get extremely embarrassed of it. And there's sometimes weeks of repression and suppression of these symptoms. They don't even let their parents know. Then, of course, as you know, the way OCD progresses, it starts having compulsions. To make it, I think, more interesting for you all as the audience, I'll just give you the most recent case that we had of a child who hadn't been to school for 1 entire month. Reason being is, of course, we found out much later, and he was just stuck because imagine, we all know as parents how the mornings and Monday mornings go, right? You have to pack your bag, get your lunch, get ready on time, run for your school bus. He couldn't do any of that because the intrusive thought in his head was, I have to do everything in counts of 3. And if I don't, something bad will happen, either to myself or something will happen to my mom and my dad. So imagine from getting up, even when you put toothpaste on your toothbrush, he would do that, but then wash it off. Put it the second time, wash it off. Put it the third time, wash it off. Now imagine that went into the bathing ritual, the soaping ritual, then the clothes, the uniform would be kept out for him. He'd wear his trousers, remove them. Wear his belt, remove them 3 times, then wear his shirt. So even as I say it, it sounds tiring. You can just imagine what happened to this 9.5-year-old by the time he was done with all these rituals, right? But the reason why it took so much time is parents think it's a phase. It's sometimes behavioral because a lot of parents feel, okay, these are behaviors because they don't have insight or perhaps awareness of what true OCD really is about. So there's also this whole stigma naturally that if I go to a psychiatrist or a mental health professional, I'll be tagged, I'll be labeled with a diagnosis. And I think the biggest fear with parents is medication. And, there's a big myth, at least here in India, that once you start on medication, you may have to be on it for life. It'll cause side effects. It'll damage my child's liver, kidney, weight gain, reproductive organs, all of that. Fear of being judged is a huge thing because as a parent, sometimes, especially parents look at it as a sense of feeling from a parenting perspective. And so that's the first part of the childhood OCD aspect and the delay of intervention. The second big aspect that is even challenging for us or as mental health professionals is the comorbidity and the OCD spectrum disorders. because sometimes, especially in children, you can have a very high functioning autistic child or a child who is diagnosed on the spectrum and yet manifest these repetitive, intrusive thoughts and behaviors that could get misdiagnosed as OCD itself. You have conditions like just simple hoarding behaviors in children where they store and hoard a lot of things, which could be mistaken for that. There are so many kids now with the emergence of anorexia or eating disorders and body dysmorphic disorders, which again lead to intrusive thoughts about how your body looks or dysfunctions based on that. And then, of course, you can have vocal tics, which is part of your Tourette's disorder. And the main differential is this a delusional disorder or the onset of early psychosis and schizophrenia? So there is a spectrum study based on that. And sometimes it could be one or the either. So I think to be really clear of what's really rational, and of course, when you diagnose, say, a delusional disorder or schizophrenia, you just can't make it based on the intrusive thoughts. There are other symptoms that go with that. So, and if it's OCD, there are other symptoms that go with that too, right? So that's the importance. And I think that's the struggle with child and adolescent OCD and its interventions. But I think we really need to take time out, carve time out as professionals, and give enough time to the children or teenagers to truly assess, because I truly believe that the earlier you diagnose accurately and you start the early intervention, whether it's either through cognitive behavior therapy or medications, you have really, really fantastic outcomes, especially with children.
Well, that's a very positive note to end on. And I think it's a very powerful story that you shared with us, really, of the child, who was suffering so much and so much distress to the family also. So I'd like to move now to just, give us some hope as to how we can treat this and live with it, because one of the things that took me a long time to learn was really how to live and thrive with my disorder. It is not the sort of thing that comes very easily. So I'm just wondering if we can, spend some time delving into that. So, Ms. Cadabam, could you tell us a little bit about treatment options and also the role of therapy in particular for both all the demographic groups that we're looking at, which is, whether we're looking at children or adolescents or adults?
Right. So I think the first step to the treatment of OCD will be where we're able to identify the distress that OCD is causing and taking the courage to speak up about it. I think, like Dr. Marker rightly said, it's very embarrassing. It can be very shameful to a lot of people to even share with your partner or your parents or anyone that, these are the kind of thoughts or these are the kind of compulsive behaviors that we've been doing. So I think the first step would be taking the courage, owning it up and say, there is a problem and we need to do something about it. Moving from that is, I think, because of high comorbidity with OCD, I think getting the right diagnosis, the accurate diagnosis, I think would be the next step. Psychological assessment like Y-box help us understand, the severity or the intensity of the disorder itself. And then some of the most effective treatment options for OCD, one, of course, is the pharmacological interventions, the medication. And moving on beyond that would be ERP. It's also known as the exposure response prevention. So exposure response prevention is basically, it's with a trained psychotherapist who's been trained under the ERP treatment itself. So exposure is where the client is helped to understand how they can confront these thoughts, images, objects, all of that. And response prevention is where you're making a choice to not do what the thought is sort of asking you to do, the compulsive behavior, while you're still experiencing the anxiety, right? So that's breaking down what ERP basically is. So the way it is done is in a therapeutic conversation, cognitively, it's broken down in terms of what are the distressing thoughts. Now, for example, if it is, say, fear of contamination, now that can come from touching buttons in the lift to shaking hand with others, touching doorknobs, all of those things. So helping the client break it down in terms of what are the things that sort of triggers the anxiety and the fear of contamination. So breaking it down, getting the client to rate it, the thing that's most distressing to least distressing. And then it begins with the least distressing. So you basically allow the client to have exposure to each of those one step at a time, allow you to go through the anxiety, and how when you do it over and over again, you see that the anxiety sort of tapers. When you see that there is no outcome of what you've been fearing, that doesn't come through. So ERP and cognitive therapy in terms of psychotherapeutic interventions are the ones that are most effective for OCD as per research.
Oh, it's interesting just to show that there are proven methodologies that can work for dealing with these. One question I'd like to ask all the panelists, actually, whoever would like to respond is, again, one of the responses I've had when I've been giving my talks on bipolarities, I've really had to say that just because you have mood swings doesn't mean you're bipolar. So, because people often tend to think, oh, I have mood swings, maybe I'm bipolar also. And here, how does one distinguish anyone listening to this between anxiety or some fears that you might have, or some even superstitions? I mean, we live in a country with a lot of superstitions, right? Do this, tie this necklace, or wear this ring, or wear this amulet, and those kinds of things which are related to some particular outcome. How do you distinguish between all of that and normal anxiety and OCD? If anybody would like to answer that question. Maybe Dr. Reddy, you might be seeing some of this.
Yeah. I think you raised a very important question. This was actually partly answered already by Dr. Sarosh. Superstitious behaviors, or for that matter, rituals and intrusions are common in people. There are studies both in adults and children which show that more than 90% of the people get some kind of intrusive thoughts, or we all know that we have performed certain rituals when we were children, maybe sometimes even as adults. The main difference between the so-called superstitious behaviors and rituals that are seen in general population and in those with OCD is that they are not a source of distress or anxiety to you. If you see, for example, in crossing a road, if you see a cat crossing from left to right, if you're a superstitious person, you might say something like this and move on. But if I have OCD, I will make sure that there are no cats on the road before I go to the house. I will send some people in the house, go check whether a cat's around. And if I see a cat, then I come back and perform elaborate rituals to undo something to prevent a harm, or, something like that. So the superstitions are quite common, not just in India, all over the world. But when do superstitions become obsessions, and when do they become compulsions? That is when they are a source of distress. They start interfering in functioning, and a lot of them are very, very time consuming. You can spend hours performing those rituals. I think that's an important difference when you want to differentiate from normal reputations and superstitions. The second, anxiety. Now, for example, we all get sometimes, anxiety is also varies from person to person. If it's very, very severe anxiety, then you might get some other diagnosis, such as panic disorder or an anxiety disorder. But then you can be anxious, for example, you send a child to school, and then instead of coming at 5 o'clock, child comes at 5:15, 5:30, you have a little worried, okay, what happened? Maybe you can make a call to the driver and then leave it at that. But if I have OCD, I perform so many compulsions and I'm on the phone all the time to see that nothing dangerous happened to my child. And to the point that, everybody gets upset with your preoccupations, and not only yourself. So I think normal anxiety is something which is not a source of distress. I wouldn't call anxiety. Perhaps some degree of apprehension, can be there in a lot of us. So, but then it's not time consuming. It doesn't come in the way of our life. I think these are the major differences, major points to differentiate OCD from other problems. And OCD is not a fashionable diagnosis to have, not a fashionable name to say I have OCD. I've seen many film actors and celebrities saying, he has OCD, she has OCD. And if you see their lifestyle, I refuse to believe that they have OCD, because if they have such severe OCD, they can't be really, performing so well in their lives. So I think we should not trivialize the diagnosis. That's very, very important.
Okay, thank you. That's really important for us to establish the difference between the normal anxieties we go through and, the kind of distress it's causing us, and the normal superstitions that we all live with, and the distress. Dr. Motivala, maybe I'll just turn to you. Being from LA, I don't know if you've heard about Leonardo DiCaprio's experiences with OCD, and, picking up on Dr. Reddy's point on actors and celebrities and their OCDs. Is that something you could talk to us about?
I don't know in his personal life what's happening. I know he was in a really good film about OCD that it's called The Aviator, and I thought it had a pretty. It's really difficult to depict OCD in film. It's a really varied problem, first of all, and I think sometimes in the films it has a history of being depicted in kind of a overly simplified way, but The Aviator is a pretty good depiction of it. I think OCD affects it shows no mercy to anybody. So whether you're a celebrity or not, whether you're really intelligent or not, whether you're really talented or not, it strikes with a lot of equality. It doesn't matter. So I think it kind of goes back to a basic, like a fundamental problem in mental health, is that it gets short shrift. Mental health treatment is not respected in the same way that medical issues are respected. They're not treated as significant or important as medical issues. And there's a bias that people have that mental health issues can be dealt with individually, whereas dealing with medical issues individually would sound ludicrous. If you have a broken leg, or if you have an arterial blockage, the idea of fixing that on your own, if you're a strong person, you should be able to handle that on your own. It sounds hilarious. It sounds ludicrous. But these are some of the expectations that people have about mental health issues, some of which are quite severe. In OCD and in bipolar disorder, there's a range of impairment and distress that come up. But with the clientele I work with, I work with some pretty severely disabled folks who really need guidance and help. So I think these biases that are out there are really, really harmful. And, the biases combined with stigma about having a problem that you didn't even cause, I think is really unfortunate. So.
I mean, my catchphrase right now is mental health is a team sport. That's something that I've been saying a lot, that,
I like that.
It's not something like COVID where you can isolate someone in a room and just expect them to recover. So, Dr. Marker, with many mental health conditions, really it's seen as they're seen as personality flaws, right? And they're not seen as conditions. We often tend to say, oh, so-and-so is behaving like this because they're having a bad mood, or especially in the case of OCD, it's really seen as, their personality. How does one distinguish, but how does the average person distinguish between what's a personality issue and what's a medical condition that requires attention?
Sure. I think what we all have to be on the same page on is primarily when you look at the aspect of mental health, it has to be viewed and perceived by everyone as an actual illness, right? I mean, it is eventually termed as something clinical and not behavioral or psychological or personality based. That's the main differentiation, that when you look at a diagnosis and a mental health professional or a psychiatrist has diagnosed anxiety or OCD or clinical depression, it is a neurochemical imbalance in the brain. I mean, we do have widely researched and studied neurochemicals, primarily that of serotonin, which is known to be responsible for depression, anxiety, and OCD. You have dopamine, which is another well-researched neurochemical that controls thoughts and manages impulses, etc. And with, yes, limited research, we do know that there is some dysregulation and disruption of these neurochemicals that cause these symptoms. They come out of the blue. Now, when you look at a personality or even an emerging personality disorder, when you have a loved one giving you the history about symptoms, even in a child, they will always say, but these were there as far back as you can remember. They've always been part and parcel of my child or my young adult who I'm looking after. When you have a disorder or an illness, like I said, again, when it's something clinical that you've diagnosed, 2-3 things are important. One is, it is an insidious onset. It's not like overnight these symptoms just come, right? Like I said, with OCD also, and in children, it starts slowly trickling in and becoming so thought-based that sometimes you actually believe that this is just really me. I know so many people who've gone through chronic long phases of either depression, anxiety, or OCD, and they truly believe that this is perhaps my personality, to just be an overthinker or be an obsessive personality or be an anxious or a worrisome kind of a person. But they don't even realize that because they've suffered perhaps for so long and they've not sought the right kind of help or diagnosis, it is actually a condition because of that imbalance neurochemically, right? And when it is again clinical, it actually creates, as all of us have clearly mentioned, dysfunctionalities. So when you look at either your basic activities of daily living, like some clients will tell you that even getting out of bed in the morning is a nightmare. And I have a young 22-year-old woman, for example, who's barely left her house 2 or 3 times in the year because of her chronic OCD symptoms, right? So the dysfunctionality, the level of fear and anxiety that these symptoms caused, and it deteriorates. It's also known to deteriorate all aspects, like in children, the academics, the focus, the concentration. There is cognitive decline when you have these imbalances that go untreated. And the second thing is, it's not triggered by something. I truly believe when it's truly a clinical entity, like for example, yes, when we lose someone we love to death, we are all going to go through death and bereavement and clinical kind of symptoms of depression, but that doesn't mean it's clinical depression. It's caused, or the low feelings or the anxieties are because of either death or loss or financial instabilities or a separation or a divorce, etc. Then again, those come in the category of emotional and psychologically based problems and not clinical. So I hope I've kind of tried to address the difference between a personality and an emotional or psychological issues versus something that is truly clinical in nature, caused by a neurochemical imbalance that sometimes needs pharmacological or medical intervention to get better.
Yeah, but just to kind of maybe just to probe that a little further, could there not be psychological triggers that cause the chemical imbalances?
Of course there could be. I'm not saying no, but now say, for example, since we're on the topic of OCD, now till date in my 22 years of practice, I have not had a case in children or adults where there's been an actual trigger or a psychological cause.
Okay.
So I would say more than 90% of your typical classical OCD cases have had no behavioral or psychological or emotional triggers that have caused these symptoms. They've literally come out of the blue, but like I said, it's taken time for them to reach help or seek help, but not when it's again clinical. But then again, that's my opinion, but I'm not saying they don't contribute. They definitely do. But like, for example, I've never had a kid who's had OCD, who's had, say, said to me also, or by the parents, that I've been bullied or I'm struggling academically and therefore I'm washing my hands or things like that. So when you have OCD symptoms, yes, the pandemic and the whole fear of the virus and contamination and, being in lockdown has emotionally and psychologically maybe compounded and worsened and triggered contamination OCD symptoms. But that's specific to the last 2 years. I wouldn't say it's a generic thing with OCD, at least.
But then it's mostly genetic. I mean, the origins of it, or
with mental health, you can't say it's only it's everything. It's like you said, it's a team sport in the same way. there are multiple dynamic factors that contribute to mental health illnesses. So yes, there could be genetic contributing factors, psychological factors, early childhood traumas, right? So those are very clear, what do you say, as triggering factors, or that they create certain situations that could lead to mental health concerns. But like I said, those are mental health concerns that all of us go through. All of us go through stress and anxiety and emotional setbacks, right? But it's not clinical in need of medical intervention. So that's the one differentiating aspect.
We actually have a bunch of questions. I'll go through them, not all of them immediately, but one of them I think which is relevant to this is this whole question of caregivers. So the role of the caregiver is very important in any illness, and especially mental illness. What should caregivers for people with severe OCD keep in mind? Maybe Ms. Cadabam, if you could answer that. I think you're on mute.
Right. So I think as a caregiver, the first and foremost thing is to learn about the disorder itself, as to what it is to have OCD, what it is that the person is going through. Okay. And what are the things that they need to watch out for. So sort of helping the person by knowing what it is and what should be done, what can be done. I think understanding the psychoeducating yourself about the illness. Also, sometimes what happens, many family members sort of become enablers to the symptoms of the patient itself. So, for example, if someone does have a tendency to check, they sort of reassurance seeking is another thing that many of them, do you think I've forgotten something? Do you think I harmed someone? Do you think I did something wrong? So in such cases, many times family members sort of act as enabler that sort of adds to the anxiety and, amplifies the symptoms of OCD. So I think being aware of how to help, when to help, and in what way to help. I think working closely to understand if the symptoms are increasing or decreasing. And then I think that is something as a caregiver they should help.
So yeah, that's very interesting. And Dr. Motivala has said that a great starting place to read is When a Family Member Has OCD, written by John Hirschfield, as a way of educating oneself. But just to build on your response, could you tell us about one thing that they should do and not do? Just, when you're describing how they can and cannot help, something they should say, something they should not say, a family member.
Not very sure of that.
Anyone else want to just take that up? Dr. Reddy?
There is no one answer to say yes or no, but I think it's particularly well known that in people with severe OCD, family members often participate in the rituals and they change their family routines to accommodate patients' symptoms. For example, all of us have to go to work at 9 o'clock. And if someone in the family is occupying the bathroom for 2 hours, we rearrange our schedule. That is accommodating OCD. Or, for example, you have OCD, but you make everybody else wash and clean instead of you doing it. So these kind of accommodative behaviors are generally known to interfere with the treatment of OCD, and they can negatively affect the overall treatment response. So one thing that can be done, it is not done it in one go, usually done in a collaborative manner in therapy, that you agree upon, sit in a session and see what kind of accommodative behaviors family can withdraw gradually with full consent of the person who has OCD. So particularly in children, it's well known that not involving family members in the treatment can be quite detrimental. Treatment outcomes can be poor. And I know for myself, because we have done a lot of research in that area, even in adults, if family members are very much involved in rituals, and they can really affect the outcome. But you can't simply say, don't stop doing everything today. It's too overwhelming. Anxiety is overwhelming. It's not that easy, particularly for people who have severe OCD. Yes, the one line is that, yes, it's good not to reassure, good not to accommodate their behaviors or rituals, but then much easily said than done. It has to be very, very gradually withdrawn in a collaborative manner in the therapy.
Okay. So I think it's a very subtle, nuanced role for the caregiver also. And I'm sure that in something like this, the caregiver's role is just really, really important as part of the overall treatment. We have a lot that we could talk about. We also have a lot of questions. So I'm going to ask you a few more questions, and then we can go back to some of my questions. How do we deal with a person diagnosed with OCD in the classroom or college? Would there be any specific aspects to keep in mind as an educator or at the institution level? This is Linda Dhakul who is asking this question. Anybody would like to answer that at a classroom level? Yeah, Dr. Marker.
So basically what we try to do in Bombay recently is we've created Minds Matter, which is a mental health curriculum introduced to schools, because as you know that most, if not all, mental health concerns do have their age of onset whilst the child is yet in school. And as you rightly said, it could be different generations or parents or grandparents that don't have that kind of awareness and knowledge. So I think the first step for all educational institutes is to create a knowledge hub and create awareness, but through the curriculum. Just having a one-off lecture on, say, sex education, and then when you're in grade 7, having the puberty changes talk, and or maybe having a one-off, interactive workshop on suicide prevention is not going to change much. And when I talk about a mental health curriculum, it's of course age and grade appropriate dissemination of information on all aspects of mental health. And the reason for that is if then you have a friend, because I truly believe that peer influence also plays a huge role in a child's life or anyone's early life time, right? And when you have awareness building up, if you're going through something yourself, like these intrusive, repetitive thoughts, they could be extremely, like we said, embarrassing, especially if they're based on religion or they're based on sexual thoughts, etc. That if a child also has heard the correct age-appropriate information, say specific to OCD, and you're then automatically giving them steps, not just to manage that, but to seek the right help, who to talk to, how to talk to someone, how to reach out for help, and how it's absolutely okay to not be okay, but not okay to not reach out for help. And when you have it disseminated, so what we're doing is we're taking out one subject period out from the curriculum and the academics and making this mandatory across grades 1 to grades 12. So one period a week for this class and talking about a range of everything that's connected, not just with life skills, with personality development, but even something like the importance of failure and why it's important to fail, or the importance of stress management, or the importance of just understanding your own thoughts and how to manage your thoughts and manage your emotions. So starting at that grassroots level to even understanding what self-harm is, because today you have increased substance abuse, self-harm, suicidal attempts, and there's so much happening with our youth that I think it is very, very important to start honest, open, age-appropriate discussions within the classroom. I think that is the first step of what I call as early intervention.
No, I mean, it's a great initiative, especially to make it part of the curriculum. Like one of the talks I've started doing is what I wish I knew about mental health in my 20s, like covering some of all these, very difficult topics. But just to say, what could an educator really do? Like if they've got a child in the classroom who's got OCD, right? They've got awareness going on, but do you accommodate the child, or do you then, how are you part of the treatment? Because you're obviously part of the child's or the college or the student's daily environment. So how do those
So it's two parts. One is, I think, educating the other kids as well. Because sometimes when you have repetitive, intrusive thoughts are internal, they don't manifest externally. But when there are certain compulsions, right, it could be anything from tapping to counting mentally to anything, we allow the children to understand that this is part of a syndrome. So now, for example, just to give you a simple, quick parallel example with ADHD, we sensitize all kids what is ADHD. And as part of the educational allowances, we actually now are propagating, allowing the child to maybe take out of seat breaks versus the other way around where it was, a disciplinary issue and they had to sit in one place. So when you normalize the accommodations, you're kind of desensitizing the other aspects as well. So you're taking away the shame and the embarrassment. You're allowing the kids to be sensitized to what these conditions are. And yes, being careful not to enable the obsessions or the compulsions. So as, has been already stated, one cannot be an enabler, because when you enable things, it is very easy to slide into more repetitive, intrusive compulsions. And the second thing is definitely, even as an educator or teacher in class, to be very, very mindful on the vocabulary and the language that you use in the classroom, even when you're redirecting the child's particular behavior. And I think one word that stands out that we tell caregivers and educators is don't invalidate the symptoms. Mm-hmm. Because the child or the young adult is not purposely doing these things, like especially when we have a kid with vocal tics and physical tics, and of course he's on medication and all, but he will really be loud in class and make clucking sounds and have his visual, eye twitches and neck twitches. And it's beautiful because when he was not there in class, we had a kind of 25-minute workshop on what Tourette's disorder is, etc. And before, you could see kids getting irritated and making a face, because obviously they were distracting and stuff. But after the talk, they've beautifully managed him. So we've given the kids also tools on how to manage him, like how to maybe place a hand on his shoulder because this kid was getting very, self-conscious and anxious and worked up, and other kids could see that. So we created a buddy system. We had someone who he was comfortable with, who would sit next to him. We had written down certain instructions that would help him calm down, which we pasted in the inside of his pencil box. So these are the small things that we can do as educators within the classroom to help children like him.
I think that's fantastic. I think that again, it just highlights that, mental health is something that needs a community, and it really needs that community. Dr. Motivala, do you think any of this could translate into the workplace? I mean, how would you not accommodate, I mean, if maybe that's the right word, or how would you manage somebody with a condition such as this in the workplace?
Yeah, I appreciate the question. It's a good question, but I think the first priority is really to educate practitioners. I think there's a dearth of educated practitioners in India who can treat OCD. It's great to increase, it's really important to increase recognition in school, in the workplace, in families. But if you don't have trained practitioners who can treat the disorder, you're not addressing the problem adequately. So I think the primary, if you're going to allocate resources, I think the primary focus, in my opinion, is to put resources into training practitioners to do the treatment. It's certainly important to inform and educate workplaces. There are a lot of people with OCD that lose their jobs because of their OCD. And if there were a way to help them maintain their job while working on their OCD, that would be a great thing. But the problem is the workplace is not going to be able to, significantly help someone with moderate to severe OCD.
I didn't mean so much that the workplace will help, but I just meant how would you survive in the workplace with something like this? I do understand your question about the practitioners, and in fact, there is a question from one of our audience members about can it be tackled OCD at the primary healthcare level, and if not, then how, where do you see the intervention really helping? But I mean,
I don't think so. I mean, I hate to be the wet blanket. I don't think so. I don't think it can be tackled at the primary care level. I would think with milder forms of OCD, sub-threshold diagnostically, or mild OCD, mild diagnosed OCD, perhaps, but I think that, behavioral and or pharmacologic treatment is what's needed. So an individual on their own at work trying to sort of stay afloat, it's really difficult. And I think it's our responsibility as practitioners who are trained and educated in helping people with OCD. I think it's our responsibility to spread that knowledge and spread it as rapidly and as properly as possible.
Yeah, Dr. Reddy, just to build on that, you've had 25 years of the clinic. I mean, where are people coming from? Are you seeing any evolution in terms of the kind of people coming to seek treatment, or in terms of the awareness of it? And what do you really give us some sense of, who's coming to for help?
So our clinic is in a tertiary care center. It is the National Institute of Mental Health and Neurosciences, which is a well-known psychiatric postgraduate training center in India. So initially, we used to see people who were never treated, who came and took treatment and got well. Now, over the years, we're seeing more and more people who haven't got well because they've gone around everywhere, and then they come to you for expert treatment. We are seeing more and more of a so-called, we are not touched upon that area, the treatment-resistant OCD who do not respond well to the first-line therapeutic options. But having said that, the OCD clinic in NIMHANS is very peculiar in many sense. We are a government hospital. Whereas all other clinical services, you see a lot of poor people, coming to hospital because treatment is free. But OCD clinic is one place where you only see middle-class families or upper middle-class families. Now, but if you look at an epidemiological data, that means the community-level data, OCD is a very secular disease. It cuts across all socioeconomic groups, religion and race and, whatever you would like to say. So it's a pretty secular kind of a disease. But it obviously means that people of a particular background, probably people, rural people or people who are uneducated or lower in the, social hierarchy in terms of economic privilege and other things, they perhaps don't perceive this as a problem, or that they don't identify it as a problem and they don't come to treatment. So I see mostly people, who are educated. At least most of them come from middle-class families. That doesn't necessarily mean OCD affects only educated, upwardly mobile people, which is actually not true. It is simply the fact that I think OCD is not recognized as a problem, or they don't know where to go, or that sometimes it gets normalized or seen as an eccentric behavior and left without getting treated, or many of them may be simply embarrassed because of the thoughts they have, and they never reach a mental health professional. So it is true that there is a lag in the treatment-seeking behavior.
Yeah, so I guess this is sort of indicative of mental health in India generally, where, I think it's honestly, like, I'm not trying to be biased here, but in some parts of our society, people will even wonder what mental health is. Like, I'll just give you a small example. I go to sign books at stores, and sometimes I speak to the retail staff and they ask me, what is the book about? And I say, well, it's about, anxiety or depression or anything related to mental health, really. And they're like, what is mental health? Is that something that happens to corporate people? So it's really the word itself. And there's so much about, the word itself and how it translates into, let's say, regional languages and other parts area that forget, thinking of things like bipolar, OCD just seems so sort of more like marginal conditions for a lot of us. So it brings me to one point really is, what is the role of legislation in all of this? We had a question around there. We could maybe, Dr. Motivala, we could say that I know you're practicing outside India right now, but where have you seen legislation really play a role, and what role do you think as an outsider that could work for a country like India? And then we can obviously take it to other panelists who might like to contribute.
I think it's really important for a health consumer to know who's qualified to treat the problem that I need help with. So how do I, if my son or daughter or my wife or myself, if one of us has OCD, how do we, and we go to someone who says they know how to treat OCD, how do we know that they're qualified? So I think there needs to be some regulation of licensing. And I'll be honest. I'm confused how therapists are licensed in India. It seems the organizational structure of it seems unclear to me. In the way it works in the U.S. is that therapists are licensed in the state that they practice in, and there's certain useful aspects to that, but there's also certain problematic aspects to that. So if you're licensed in California, you are not licensed to practice with someone who lives in an adjacent state or lives in New York or Texas or something like that. So that hampers or can impair, that can create a barrier to treatment. How it can work positively is it makes sure that people in their local region, therapists are seeing patients that are somewhat local, so they are connected and aware of resources that are local to that patient. But in India, I'm unclear how licensing works. So I think the first step is, it's really important for the consumer to understand, what are this person's qualifications to be a therapist? I mean, I have a PhD. My degree took 5 years to get, followed by 2 to 3 years of postdoctoral work. So that's a lot of training. And there are other therapists who are practicing who have considerably less training. And I'm always intrigued by therapists who advertise an incredibly broad range of disorders that they can treat. I specialize in anxiety, and that's tough enough as it is. I don't do couples therapy. I don't do family therapy. Those are very difficult treatment modalities, and you need to put in a lot of work to get good at those. So I think that's the sort of very frustrating dilemma about being in India, is what are the criteria to be what are the minimum thresholds to be licensed as a therapist?
Would you like to, sorry, I'm just going to call on Neha she wants to respond to that at all? You're on mute, sorry.
Right. So I think here in India, laws are, there have been various laws that are getting governed, and I think things are getting better with time. I think one very glaring thing about treatment in India, especially when it comes to mental health, is the number of mental health professionals available itself. I think there is a great gap in terms of the number of people who require treatment to how many mental health professionals are available itself. So I think here, while I do agree with what Dr. is saying, is the gap is very high, and somewhere there are professionals getting trained with various modalities and are trying to address as many issues as possible. I think Dr. Reddy will be able to tell more on these lines, because I think the OCD clinic at NIMHANS is always very, very busy.
Yeah. So so I don't want to get into the treatment, gap, because that is a huge issue and we all know about it. But I do want to, yes, Dr. Ed, we'll come to you. But I think there's one issue is about regulation and licensing. But when it comes to the law, also issues of rights, right? And then issues of actually having access. Can the law play a role in rights and in access? Dr. Reddy, I don't know if that was what you wanted to say, but you can obviously say what you, please share your point.
The Mental Health Act that we have right now is basically right-based. That means that if I have a mental health situation, I have a right to access appropriate treatment. So in the Indian context, what do you mean by that? That means I need to be able to see a doctor, not even a psychiatrist, who has some expertise in treating mental health condition. I'm not talking about OCD. OCD is way down in the hierarchy of needs of people, okay? For whatever reasons. We're not going to that. So who are the people who can treat these people? Now, before that, I would like to emphasize one thing. OCD treatment does not necessarily mean it is only cognitive behavior therapy. that is one of the two first-line treatments. Other one is pharmacotherapy. Pharmacotherapy and cognitive behavior therapy, and a combination of these are often required for many severely ill patients. Now, if you have a hypertension, you don't necessarily go to a best-known cardiologist in the town unless you have a lot of money to go. A cardiologist, a patient with hypertension or a cardiac problem can be seen by a good MBBS doctor at a primary healthcare center. Then there's a next level. You go and actually see a psychiatrist in the nearby district center, and maybe last, if nothing happens, go and meet Dr. Reddy sitting in NIMHANS and seeing difficult patients. So there is stepped up care. I guess similar kind of situation also happens to mental health conditions. So if the doctors who graduate have enough training in basic psychiatric care, I think they can manage many of the disorders at one level, and then next level you go on to consult experts. I think that's the first level. Now, who are the people who do therapy in India? Of course, all psychiatrists are trained to do therapy, but most of them don't do therapy because it's 1-2 hours a session, and there are 50 patients sitting outside your clinic. So they end up predominantly practicing pharmacotherapy. Okay, and even in a place like NIMHANS, I don't do CBT for everyone. I don't have resources, although it's a big institution. So I reserve CBT for people who don't do well with medications. And then who are other people? Then you have a clinical psychologist who are certified, but they're a small, very few in number. So how do we actually train people to develop skills in administering CBT? Now, forget about India. Waiting period for a CBT in places like UK and America, if you want to see a proper trained therapist like Dr. Motivala, it is several months. So it's not a problem which is very unique to India. Of course, India has many more problems because like Dr. Neha mentioned, there are very few mental health professionals. So I think the first thing is not how to provide CBT to all patients with OCD. The first level is that doctors can diagnose OCD, then at least do initial pharmacological treatment, which I guess most doctors can do very well at one level, and then maybe go on to the next level. I think that for me is the most practical way of looking at this problem at this point of time.
Okay. So do you see the law as really just sort of like a framework that is guiding at best, but it's not really delivering necessarily the outcomes? It doesn't have the capacity to deliver the outcomes that we would like to see.
Well, aspirational laws should not remain as aspirations. Okay. Now, Mental Health Act, mostly discussion is all about how do I admit patients who do not want to get admitted in the hospital, and then which mental health review board I go to. So most of the discussion now about Mental Health Act is about not OCD patients. They don't come into picture there at all, because these are the people who know they have a problem and who goes and seek treatment. A lot of issues that Mental Health Act, without mentioning so much, actually mentions is about severe chronic mental ill patients where insight is very severely compromised. The only place where actually Mental Health Act very explicitly talks about it is when you want to do a surgery in people who have a very chronic refractory OCD. The other form of treatment is either you do surgery or a deep brain stimulation, then you will have to go and take permission from the State Mental Health Review Board for surgery. Now, this is only one specific issue where Mental Health Act specifically talks about OCD. But in general, the principle is it is an aspirational and kind of a right-based kind of an act. Of course, it takes its own time for all these aspirations to be realized, I guess. And then there are numerous practical aspects. Forget about OCD in daily administration issues in the hospitals, because there are so many bureaucratic issues involved in actually implementing it. In fact, most states don't have any mental health review board at all even now. Neha would know that. So there's a lot. That's why I said this is a totally different topic for discussion by itself.
No, it is. But it's important to really understand where the Mental Health Act is coming from and what it can do. I'm going to ask just one more question from the audience, and then we will look at wrapping up. There's a very common question which I get asked a lot also is, what do you do in cases where patients are not willing to go for treatment? So what is your response to that? Dr. Marker, you want to just offer some guidance on that?
That's a tough one. But you can't really physically take someone. In fact, what Dr. Reddy said, right? I mean, the whole Mental Health Act was to also prevent corruption in terms of wrongly institutionalizing, patients or taking in patients who are, a harm to themselves or others, and yet did not have the insight into acknowledging that they had a problem. And how do you give treatment without the patient's knowledge, because also you do have medication that you can administer without the client's knowledge, right? So there are a lot of these gray areas. But to answer your question, I think the constant support and knowledge building, because I think the more and more you create and build awareness within the family and the family members. And I think if most of the support structure, that's your parents or relatives or even close friends who buy into the concept of mental health, have a reality check in terms of, yes, this is something clinical, and only intervention with the right professionals would make a change in my loved one, is the first step, right? Because then you can use various ways of normalizing mental health to a person who's not willing to seek help and treatment. I think even sharing. So what we do a lot now, and because of, again, the lockdown and Zoom consults and teleconsults, I think the big fear is, like I said, I told you about this 22-year-old who did not leave her home more than 3 times. The first consult she had with me was telephonically. She did not want to be seen. She was embarrassed. She was scared to leave her house, right? And I had to use maybe 5 or 6 telephonic consults to first, buy in, build trust, build a rapport, introduce myself, do a bit of sharing. I truly believe that as a loved one or a family member, when you sometimes share your story, you kind of build a stronger kind of empathy level and understanding with your client or family member. And yes, after 5 sessions, she did finally, muster up the courage to come in. But what I'm saying is a holistic approach. Sometimes if there is, again, resistance, a professional going to the client's home can help, So there are different ways, but definitely you can't enforce or physically, like I know that when you have, say, chronic schizophrenia, or you become extremely aggressive, violent, or not in touch with reality, like anywhere in the world, you have social services, ambulatory services that come home, sedate the client, and then take him or her away. But I don't think OCD requires that kind of, intervention. But to answer your question, it's different ways to encourage the right seeking of help.
Thank you for that. That was really interesting to hear about the way that you tackle the particular patient. Okay, so we are going to now do a little rapid fire round. And when I say rapid fire, the emphasis on the word is on rapid, please. So I'm just going to ask you a couple of questions and we'll go around. So first, start with Dr. Reddy. 2 words to describe OCD. And not obsessive and compulsive. Anything apart from that?
Secretive disease.
Secretive disease. Okay. Dr. Motivala, 2 words.
Very treatable. There's hope.
Very treatable. Great. Dr. Marker?
Family support.
Family support. And Ms. Cadabam?
Difficult, but hope is there.
Okay, great. So we're all quite aligned on that. One myth that all of you would like to bust about OCD. Let's go backwards now. Neha, you want to say something? One myth.
OCD is not cleanliness and being organized.
Okay. Dr. Marker?
Disorder.
It's a sentence. I mean, it's a concept. OCD does not necessarily have to have compulsions. So when you look at your hand washing and cleaning and organizing, you can have purely severe OCD cases which are only thought-based. So you have repetitive, intrusive thoughts only without compulsions, but that is also OCD and very well treatable through medication and CBT.
Okay, great. Dr. Motivala?
How can we reduce the stigma around it, the stigma around having OCD? And can we create a world where there's a lot of love and acceptance and encouragement and support? So maybe the myths around when we see someone behaving in ways that we don't understand, we can approach it with more curiosity and compassion. So.
Nice. Dr. Reddy, the myth?
Yeah, 2 things. It is a reflection of a flaw in our character. No, that's the myth I would like to bust. And I would like to say OCD is because of low serotonin in your blood. I want to burst that myth. It's not true. There's no evidence at all. But there's something which is sold to everybody all over the world.
Okay, so wow, these are very sort of scientifically based myths that we're busting. The last one is one thing that you would tell anyone who says very casually, "I'm OCD" or "I have OCD." What would you tell them, Dr. Reddy?
Good luck, enjoy it.
Who says it very casually, like the casual people who don't have, the people who don't actually have OCD, but they say I've got OCD.
Yes, I will tell them, if they're successful people, I will tell them I wish I also had it too.
Okay, Dr. Marker.
I would just try. I always do that. I can even talk to a tree, so I would give them a long talk on what mental health is and what the difference of just a casual, because like I said, it's not just, I'm OCD. There's so many people amongst us who say, I'm depressed, or I have anxiety, or I have OCD. So I would like to tell them that no, those are just phrases we say in passing. Yes, we can all have a bit of obsessions. We can all have a bit of depression and anxiety, but it's not a mental health illness that you need to treat. And these are just lay terms that lay people use. But there is, when you talk about a disorder or an illness, it is more serious.
Okay. Ms. Cadabam? Yeah.
I'd like to say it's not a personality quirk. I think what people understand very easily is when you give them a physical health condition example and explain a mental health condition. So I think giving a reference like that, I think helps people understand better.
And Dr. Motivala?
Yeah, I would just echo the sentiments of everyone else on the panel. There are a lot of great, responses about it, and maybe just view it as a opportunity to learn more about what they're saying and what they mean, and maybe also to have a discussion about true OCD and what that looks like.
So thank you very much. It's been a fascinating conversation. I think what we've really been able to do is to get into understanding the symptoms, understanding the treatment, understanding really that one should look for distress and impairment as indicators that something could be going wrong, and this is a good time to see a practitioner. Important to find the right practitioner, which of course is always a challenge in any part of the world, but particularly so in India, of somebody who can treat. And the OCD clinic at NIMHANS is obviously a starting point, but we have other panelists who also offer their services. And I think we've also highlighted really the important role of the caregiver and the community around us, that this is something, since that is such a big part of, it affects such a big part of the patient's or the individual's daily functioning, that the important role of the community, whether that's the family environment, the school, the college, maybe the workplace, for allowing people to be able to function despite their condition. So thank you very much for joining us. And this is a series of conversations that the Asia Society wants to have in the area of mental health. So do tune in for future discussions. And thank you to all the panelists for taking this time out. And we look forward to being part of future discussions with you also.
Thank you so much. Thank you for that wonderful program that you conducted.
Yes, thank you very much. It was great.
Thank you.
Great. Thank you. Thank you.